Okay, hello everyone. My name is Taylor Fitzpatrick-Schmidt and I'm a graduating senior at Tulane University. I just completed my honors thesis in Dr. Marava's lab. I've been working there since my sophomore year, so we've spent a lot of time together. And today I'll be talking to you all about novel treatments and congenital disorders of glycosylation. So I'm just going to start with an overview of the current CDG treatments and some developing therapies that we're working on. And first I'm going to focus on sugar treatments, including MPI-CDG or CDG1B, as Dr. Marava talked about, which is treated with mannose, PGM1-CDG, which is treated with galactose, and DPM2-CDG and PMM2-CDG or CDG1A, which don't currently have an established sugar treatment, but we're working on developing those therapies. And then we'll talk about organ transplantation and how that can work as a treatment for CDG patients. So again, there are two current treatment options: sugar treatment in the diet and organ transplantation. And there are also some developing therapies, which Dr. Marava just mentioned. The overcoming the metabolite block, so treating with the activated sugars, and you'll hear more about this later in the program, and enzyme therapy for the missing enzymes. And there's a couple of companies here today who are interested in working on that or are currently working on developing that. So the first treatment we're going to talk about is adding sugars to the diet. So essentially either taking mannose, which is cranberry sugar, or galactose, which is milk sugar. So I'm sure you guys are happy to see this slide again, but before sugar chains can be made, they first have to be activated. And lots of CDGs prevent this activation, which means that the sugar chains can't be made and they can't be added to the proteins, so these proteins aren't functioning correctly. So this green sugar here is mannose, the cranberry sugar you might remember. And so in MPI-CDG or CDG1B, this mannose can't be activated, and which prevents downstream the sugar chains from being made. So by treating these CDG patients with mannose, we can increase the amount of activated sugar, make more sugar chains, and this can increase the amount of ICAM1 we have. So ICAM1, we haven't talked about this yet, but ICAM1 is a protein that is glycosylated, so it has these sugar chains added to it. And it's easy to assay, so it's one of the proteins that we look at when we're trying to see whether our treatment is working in these CDG patients. So we can use staining to look at the expression of proteins such as ICAM1 to see how the treatment is working in patient cells. So ICAM1 is present on the surface of cells, so you can see it in this diagram here, and these things coming off of it are the sugar chains that sometimes we're missing in the CDGs. So this is a picture of a stain from a healthy cell line. So the blue are the stained nuclei of the cells, so you can see lots of cells, and the red is ICAM1. So remember, red, ICAM1, this just means more sugar chains. So you see lots of red, you're seeing lots of ICAM1, and this makes sense because this is the healthy cells. So healthy cells have lots of ICAM1 and lots of sugar chains. So we looked at ICAM1 staining in these MPI-CDG patient cells. So you can see there's lots of blue, so you see that there's lots of cells present, but there's very little red. So you see a little bit of red here, but there's definitely not as much red as we saw in those healthy cells. So this is just a little flow chart of the methods that we use, but some of you may remember the patient skin biopsy, which we use to diagnose the type of disorder, and so we use these same cells in the lab to test the cells with the treatment in the lab before we're trying these treatments in patients. So by seeing if it works in the lab, we can see if it works in the patients before trying it in the patients. So it's kind of a preliminary step. And so we saw after treating these cells with mannose, you can see that there's more red present in the stain. So more red, more ICAM, more sugar chains are being made. So in MPI-CDG patients, we see low blood sugar, chronic diarrhea, liver disease, and bleedings. And after mannose treatment, 1 gram per kilogram per day, there's no diarrhea, the liver function is normal, and no bleeding anomalies. So that's a good fix for that CDG. Unfortunately, as Dr. Maraver mentioned, there are a few patients that develop severe untreatable liver disease, so it can't be treated by this mannose, but that's kind of a separate issue. But we see that this treatment is working in these patients that don't have these other underlying issues. So back to this wonderful slide. So this time we're going to be talking about PGM1. So we're looking at the activation of glucose or cane sugar. And in PGM1, this glucose can't be activated, which is important for the downstream making of the sugar chains. So without this glucose being activated, the sugar chains can't be made. And also the metabolism of this sugar is also related to the metabolism of galactose, which is milk sugar, which is what is going to be used to treat this disorder. So by treating these patients with galactose, we're increasing the amount of substrate here, increasing the amount of activated sugar, and so these sugar chains, the antennas that Dr. Maraver talked about, are restored. So you might remember this slide from the previous presentation, just looking at the clinical symptoms in PGM1 CDG. We see low blood sugar, high insulin, problems with hormones, bleeding disorder, muscle disease, and heart disease. And in the lab, we see that after this galactose supplementation in PGM1 deficient patient fibroblasts, which is just a fancy way of saying skin cells, this is untreated, so lots of blue, little red, and then much more red, more sugar chains being made after treatment with galactose. In addition to looking at ICAM1, we can also look at IgS BP3, which is a glycosylated hormone. And after weeks of treatment with galactose in patients, we see that the levels normalize, so it's low at the beginning, and then after just a few weeks, really there's this increase into the normal range. So obviously this is important because there's this increase in glycosylation and an increase in the number of sugar chains, but it also could be important functionally because IgS BP3 is a growth factor hormone, and as Dr. Maraver mentioned, sometimes there are issues with growth delays, so this could be important in improving the growth in these PGM1 CDG patients. So now we're going to talk about DPM2 CDG. So DPM2 is part of the DPM synthase complex, which is just a group of proteins that work together to do something. So in this case, DPM2 is working together with 2 other proteins to activate mannose, and this happens very early on in the process. So this early activation is blocked in this CDG. So we looked at both galactose and mannose supplementation in these cells, so thank you. Very little red in the untreated DPM2 CDG patient cells, and after galactose supplementation and mannose supplementation, there's more red appearing, so more sugar chains are being made. I also quantified this data with Western blotting, so this, you can see it visually, but it's nice to also have those numbers to see how much it is actually improving or changing. And there was a 30% increase in ICAM1 expression after galactose treatment and almost a 2-fold increase after mannose treatment. And these numbers are similar to what we're seeing in the PGM1 and MPI patients. So it's looking like it's going to be a promising treatment for this rare disorder.
You mentioned that this is only 4 days of treatment, so the cells are only treated for a couple of days compared to patients when we treat for 3 months and then we see gradual improvement. The cells are just a quick shot, like would we see any significant change should we go further?
Right. So the next step for this CDG is to do a Manos trial to see what the results would be like in patients, not just in the cells. So finally, I'll be talking about PMM2 CDG. And the clinical symptoms of this CDG include low muscle tone, developmental or speech delay, problems with balance, heart disease, and epilepsy seizures. There's more than 700 reported patients worldwide, so it's 1 in 100,000. And this CDG also has the most lab abnormalities of any CDG, so we see low blood sugar, delays in growth, hormone and thrombotic abnormalities, and coagulation defects. However, there's still no therapy besides just treating the symptoms. So we can treat the symptoms, but we're trying to work on treating the underlying cause. So like the other CDGs we talked about, PMM2 prevents the activation of mannose, the cranberry sugar, at the beginning of the process. So to help this disease, we can kind of come at it from 3 angles. So first, bring in the missing enzyme, which in this case is PMM2. Second would be bringing in the activated mannose, which is the substrate that we're missing to make the glycan chains. And third would be to treat with galactose, which again, we showed that it's been effective in treating other CDGs, so it may similarly improve PMM2 CDG patients. So this is the staining with PMM2 CDG patient cells. So untreated, lots of blue, very little red. So lots of cells, very few sugar chains being made and added to proteins. After galactose supplementation and mannose supplementation, we see more red in these cells. So more sugar chains being made, more functional proteins. And there are currently ongoing clinical trials with this galactose supplementation, and there was no evidence for a clinical effect after mannose supplementation. So we're not really sure why this is, why we see this increase in the lab but not in the patients. So this is a table showing an overview of experimental therapies in treating human CDG. So kind of the next step in determining, in looking at CDG treatments is gene therapy, which has been used in other metabolic disorders to treat, and it hasn't yet been examined to see if it can be used to treat CDGs. So we're interested in looking into that. Also, chaperone therapy and enzyme replacement are currently being developed, as well as substrate correction. Again, this mannose 1-phosphate, which you'll hear about next. So at the beginning of the presentation, you may remember I said that there were 2 kind of treatment options, sugar treatment and organ transplantation. So now we're going to talk about organ transplantation. So this is a treatment for CDG subtypes that only affect one organ. So if that organ isn't functioning properly, then you can kind of switch it out for a new organ that will function, and then that can cure the CDG. So for example, DOLK1 CDG has cardiomyopathy, which is failure of the heart. So if you switch out the heart, get a new heart, it treats the CDG. Similarly, in MPI-CDG and TMEM198 CDG, the liver isn't functioning properly, so if you switch it out, liver transplant, it helps these patients. And finally, in PGM3 CDG, it's an immune disease, so the bone marrow isn't making all of the antibodies and killer cells that you need for your immune system to function properly. So switching out that bone marrow, we can help these patients. So that's all I have for you all. Thank you all for listening, and I can take any questions.